Thank you, everybody, for joining us on a Saturday evening. Welcome to this month's forum discussion. Today, we'll be talking about Ayushman Bharat Pradhan Mantri Jan Yojana, which was introduced in 2018. And the primary aim of this scheme sort of was to make healthcare more equitable in India, with the aim of finally reaching universal health coverage. Recently, in the Lancet Regional Southeast Asia, from the Association of Socially Applicable Research, which is a non-profit think tank, a report was published on this scheme, discussing if this scheme has successfully helped India make healthcare more equitable in India. And today we have Dr. Sweta Dubey with us, who is one of the leading authors from that paper. Thank you, Sweta, for joining us. I'll hand it over to you now to take the session forward. If you could just start with a short introduction and then we can go ahead.
Hello, everyone. Thank you so much for joining, as Parth mentioned, on Saturday evening. I am Dr. Sweta Dubey. I am co-founder and managing director of Association for Socially Applicable Research. I will be speaking with you all today, and we'll be talking about our work on Pradhan Mantri Jan Arogya Yojana. So, Parth, if it's okay, I can get started then. So I'll be sharing my screen. And so today's topic of discussion is equity of supply and utilization of services under PMJ. This was a policy analysis by ASAR, and I'm really privileged to discuss our findings and our final conclusions from the paper. So before we go into Pradhan Mantri Jan Arogya Yojana, I would like to discuss a bit about the history of government-funded health insurance schemes and social insurance schemes in India. So, Pradhan Mantri Jan Arogya Yojana is a kind of government-funded health insurance scheme. So initially, like the initial social health insurance schemes that started were the ESIS and the central government health schemes, which were started like before 1960s. In 1997, for the first time, a state-level health insurance scheme was started by Maharashtra government. So this was like a landmark in the journey of health insurance, because most of the health insurance before this were at national level. It was for the first time that a state decided to give its poor people the and insure them for their health costs. Later, another landmark scheme was the Universal Health Insurance Scheme. So for most of us, we think that RSPY was kind of first national level government funded health insurance scheme that protected poor. But before that, in 2003, the government tried to start a similar scheme for entire population and not just the below poverty line population. However, the scheme was later converted into only for poor population. But it didn't work out and was like scrapped in an year. Similarly, in 2004, a similar scheme was launched and was scrapped. It was then in 2008 that RSBY scheme was launched and almost lasted for a decade. It was like a landmark scheme and has been a topic of discussion and research even till today. Then in 2018, Pradhan Mantri Jan Arogya Yojana was launched as an improvement over RSBY scheme. Its model is kind of similar to RSBY with some improvements. Other than that, you can see like there's a list of schemes launched at state level, national level for specific population group, and we have like a long list of various schemes that India has been doing to fund health insurance of people and population. Going ahead, let's now focus on just Pradhan Mantri Jan Arogya Yojana. And before we talk about equity and how it is helping the poorest people to get the services, I would like to give a brief introduction about the scheme. So while talking about any health insurance scheme, we look into three main factors. It's cost coverage, population coverage, and service coverage. And that is what this figure is also showing. Um, the x-axis here over is population coverage, y-axis is service coverage, and z-axis is cost covered. We actually try to compare these three points across RSBY and PMJ. And when you try to like construct a diagram across these three axes, you get something what is known as UHC cube. So this is a comparison of UHC cube of RSBY versus PMJ. Clearly, the coverage of PMJ, which is like the light green cube, is much higher than RSBY, which is the darker green one. Now coming to details. So the cost covered under PMJ is like 2 rupees 5 lakh per household. The population it covers is bottom 40% population, which accounts to approximately 50 crore beneficiaries. For choosing its population, it uses deprivation and occupational criteria and applies it to socioeconomic caste census to get the list of beneficiaries. Other than that, RSBY beneficiaries are also included, and states can decide to include some extra beneficiaries, some extra population group if they want to. As of now, 33 states have implemented PMJ either in combination of their state scheme or as a sole health insurance scheme for poor. Um, Three states and union territories, which includes West Bengal, Orissa, and New Delhi, have not implemented the scheme. Coming to service coverage, the current packages that are provided are health benefit packages 2.2. It includes 920 health packages, which consist of 160 procedures across 24 specialties. The service coverage has increased like a multifold as compared to RSPY. These services can be accessed across public hospitals and empaneled private hospitals. And as of July 2021, there were approximately 23,000 such hospitals where beneficiaries can get services. So this is a very basic introduction to structure of PMJ and how we looked at it. Now coming to some financing aspect of the scheme. It is very important to understand the financing of the scheme because the aim of the scheme is to provide financial coverage to people or financial protection to beneficiaries that are covered under the scheme. So it's funded both by state and central government, and there is a predetermined ratio how much state will contribute and how much center will contribute. And this ratio is devised by Ministry of Finance. So in most of the states, the ratio of government of India versus the state is 60 to 40 in terms of how much money they're supposed to put. But in terms of northeastern states and Himalayan states, the government of India puts 90% of scheme funding, and the states put 10%. So as you can see in the figure, this is just a very basic figure of how basically health is financed in country. So this is total health spending, including the government and the private, and external health spending. So three components. Government health spending can be central and state. Then private health spending can be out-of-pocket spending or from corporates or NGO. And external health spending is something that comes from outside of the country. So now PMJ scheme gets like around 0.075% of our GDP. This scheme, the spending on per capita by the scheme is like rupees 126. But when we actually looked into the per capita out of pocket expenditure on an average, like an average person is spending, it's like around 2,400 rupees. So the money that the scheme is spending currently on its beneficiaries is like 20 times less than what they are spending out of pocket. So serious concerns have been raised, like whether the money that the scheme is putting in is that sufficient to like finance the people or provide any health care to beneficiaries. So to understand how much money will be actually required to run the scheme, the 15th Finance Commission in 2019 estimated that around 2,800 to 28,000 to 74,000 crore rupees will be required to run PMJ in 2019. And what was allotted to PMJ was like 6,400 crore or something, which was like 88 to 95% less than the estimate that was given. So it's quite clear that the money that is being put into the scheme is not enough to run the scheme in its current form. And as I mentioned, the per capita expenditure on the scheme is 20 times less, like way less than what an average person is spending on health. So overall, there have been concerns that financing of the PMJ is not adequate to run or to achieve the objectives that have been laid by the scheme. Other than just being underfunded, there's one more issue in financing that needs to be addressed, and that is financing of PMJ with respect to overall health financing. So, as this figure shows, like between 2021 and 2022, the overall health financing increased by 16.3%, and PMJ financing increased by basically budget allotment increased by 166%, which means that the overall budget increase has not been able to like take up the speed of increase in budgetary requirement of PMJ. So there have been concerns that PMJ is taking away from other health budget sections, which includes non-communicable diseases, communicable diseases, and family welfare. So this is again a concern that has been raised. So PMJ is underfunded, and although it's underfunded, it is like taking away from other scopes or other sections of health budget. Um, the most important thing in all of this is to basically increase the overall health funding so that PMJ funding can also be increased and other health sections are not affected. Now, before we go into equity of various dimensions of healthcare, let's first look whether the funds that are allotted across state by center are they equitable. So to look into this, what we did was like we saw out-of-pocket expenditure per capita in Indian rupees for 2017-18, and then we see how much fund did center allotted state-wise in 2018-19. And as you can see, the fund allotment is not equitable. For example, states like Uttar Pradesh and Andhra Pradesh and Kerala have higher per capita out-of-pocket expenditure, but receive less fund, and Tamil Nadu with lesser per capita out-of-pocket expenditure receive more fund. So there's a serious need to look into how much money should go into states, depending on how much money they are spending as out-of-pocket expenditure. Now coming to the main topic of discussion, that is equity in utilization and supply of PMJ. So when we talk about supply, there are various factors that you can look to check whether the supply is equitable or not, which includes the hospital empanel, manpower, infrastructure. Although we wanted to look into all of these dimensions, data was not available for manpower, infrastructure, and other variables. The only supply factor we could look into was a number of hospital empanel under the scheme. And if you just so sorry. Is my screen visible? I think I
Your screen is visible. Slightly
okay.
more developed. That's all.
Yeah. Okay. So yeah.
We can still see the
With,
PowerPoint, the first slide.
you can still see the first slide only.
Yeah, maybe just stop sharing and reshare once.
Yeah.
Also, if anybody has any questions so far, please feel free to write in the chat box. We'll take up questions at the end. Any comments, thoughts, any personal experience in this scheme also, you can sort of share it in the chat box.
Yeah, can you see the geography slide
Yeah.
now? Yeah, cool. So as I was discussing earlier, the first figure is about number of hospitals empaneled per 1 lakh beneficiaries. And you can clearly see it differs a lot across various states. Rajasthan and Madhya Pradesh have like just less than 2 hospitals per 1 lakh beneficiaries, and on the other hand, states like Gujarat have like a lot of hospitals per 1 lakh beneficiaries. So supply is clearly inequitable geographically. Now coming to utilization. So for utilization, we used mainly two uh, two indicators, and which was like claim volumes and claim values. So claim volumes were kind of equal to hospital admissions in our calculation, and uh, this map is about claim values. So it's clearly visible again that this is inequitable across various states. The hospital admissions in Madhya Pradesh, Assam, Maharashtra is like very low as compared to Gujarat, Kerala, and spending per capita is very low in Rajasthan, while it's quite high in Gujarat, Maharashtra. Especially for geography, we also looked into the percentage of eligible beneficiaries enrolled across states. So that is again inequitable. The performance of Maharashtra, Karnataka, Bihar, Arunachal Pradesh has been quite poor in terms of enrollment, while states like Assam, Jammu Kashmir, Ladakh have been doing quite well, almost reaching to enrolling the entire eligible population. Um, so geographical picture shows that the services are not equitable in terms of their supply and utilization. There's also one more concept in geography that needs to be seen, and that's portability. So, portability basically means that any beneficiary of PMJ can avail scheme in any state. So, basically, you're not bound by state boundaries. A beneficiary from Madhya Pradesh can avail scheme benefits in Maharashtra. Uh, so, this is an example of portability. So, in portability, if a patient is traveling from a state to another state. The state of origin, so basically the state where the patient belongs to, is known as outgoing state, and the state where the patient goes for treatment is known as incoming state. So as of now, about 1.4% beneficiaries are using portability. Portability for high value claims and very high value claims are higher. Most likely, the portability claims are for tertiary services like cardiology, cardiovascular surgery, orthopedics. So most of the patients who are availing portability, they travel from MP, UP, Bihar, Jharkhand, and Haryana. So these are the major outgoing states, and they travel to Gujarat, UP, and Maharashtra to avail services. So these are the major incoming states. Beneficiaries who are staying or living in aspirational districts are less likely to use portability services than non-aspirational district beneficiaries. This is important to note because aspirational district beneficiaries already have less health services available to them in their own state, and then they are not traveling out for availing services, which means they are not using portability, which further decreases their access to healthcare. This table shows portability depending on specialty. So whatever I described right now was about overall portability. This table is about portability across specialties like cardiac care, oncology, palliative service, and breast cancer. So all of them are around 2.4 because most of them are like high value claim services. As you can see, Gujarat, Maharashtra are almost incoming state in almost all of these specialties. Madhya Pradesh, Uttar Pradesh, Haryana, Bihar are major outgoing states in most of these specialties. So the same trend in terms of incoming and outgoing state is seen specialty wise as well as it is seen in at national level. Uh, Now coming to the previous entire discussion was about whether the utilization and supply is geographically equitable. Now we will look whether the utilization across public and private sector is equitable or not. So this figure is basically distribution of private versus government empaneled hospitals across various states. Overall, in terms of um, entire supply and utilization for private hospitals are on higher side. For example, 56% of empaneled hospital overall are private. 63% of claim values is contributed by private. 75% of claim value is again contributed by private hospitals. Uh, Bigger states like Maharashtra, Haryana, Rajasthan, and Punjab have higher private empaneled hospitals, while northeastern states and northern states like Jammu Kashmir and Ladakh have less private hospitals. Uh, in terms of majority of or top claim private hospitals, 19 of the 20 private hospitals by claim value are empaneled only in two states, Gujarat and Tamil Nadu. In aspirational districts, private hospitals are lower as compared to non-aspirational districts. Males are more likely to use private hospitals as compared to females. SC/ST populations are more likely to use public hospital. So again, in terms of equity, the supply and utilization is not equitable across public and private. Private hospital is taking larger share of almost all indicators, starting from empanelment to claim values. A larger share is contributed by private hospitals. Uh, Now coming to next dimension that we saw, which was like male versus female, basically sex of the beneficiaries. So enrollment was almost equal for male and female. But although the enrollment was equal, volume and value of claims was higher for males. Uh, Average per capita value of per claim was higher for males. High value claims were higher for males. Portability was higher in males. Readmission and mortality rates were also higher in males. Males used more private hospitals as compared to female, as I mentioned in the previous slides as well. The services were using were more likely tertiary, and females were using mostly secondary services. When we looked into the top 10 specialities as per claim volume, six of them, which included general medicine, general surgery, oral surgery, orthopedics, urology, cardiology, and pediatric medicine, were used more by males as compared to OBGYN, ophthalmology, and medical oncology, which were used more by females. In terms of top 50 procedures, almost 60% of the top 50 procedures were used by males, and only 40% were used by females. This figure is about hospitalizations across states, and this shows person-female hospitalization. The figure is specifically about private hospitals. So with across states as well, you can see the inequity, how states like Gujarat, Maharashtra, Karnataka, Andhra Pradesh have lesser private hospitalizations for female, and the states like Madhya Pradesh, Kerala have higher private hospitalizations for female. Again, in terms of sex, it looks like males are able to access more care under PMJ as compared to females. Now coming to next dimension of age. So almost 51% claims were used by age group 19 to 50, which makes sense because this age group contributes to almost 47% of population. Average age of people using PMJ was 42.2 years, but the median age of Indian population is 28.7 years. It still makes sense because older people are going to access more health services as compared to younger people. High value claims are more prevalent under five children and those above 50. This is also logical because most likely under five children use claims for for services like congenital cardiological diseases or congenital surgeries, and those above 50s use services for cardiovascular diseases or renal transplant. So all of these are high value claims, and most of the high value claim associated diseases occur in either age group under 5 or above 50. Portability is high for 24 to 50 of 55 years age group and low in 60 above 65 years age group, which shows that old people do not prefer to travel to access healthcare. Readmission group is highest in children and lowest in 20 to 25 years age group. Average age of mortality is 52.2 years, which is much lower than life expectancy. So it is again logical because people who access services or are suffering from severe conditions are going to die earlier than the average life age of a person in the country. When we look specialty wise, so this is the median age group of beneficiaries across various specialties. So it obviously varies. Some of the important trends that needs to be looked into is like anemia. So it's more common in the reproductive age group of women. Cataract hysterectomy is more common in older people. So it's important to look into these trends because we can cater or we can design our services, design hospital packages and procedures according to the need of the population. Uh, so this was the basic look into the utilization pattern age-wise. Um, it's very difficult to comment on the equity because the requirement of various ages are not the same, but we still wanted to look into what kind of pattern we see if we see utilization of services across various age groups. Now coming to the next dimension of caste. So these two figures are hospitalization percentages, again in private hospital for SC and ST population. So you can see that there's a variation across various states. Other than the variation, the overall contribution of SC and ST population is 5% and 2% respectively in private hospitalization. While it is to be noted that the the total population of these caste groups is almost 28%, and entire SC and ST population is eligible beneficiary under the scheme. So the utilization in private sector is quite low as compared to the population or the percentage of beneficiaries they are contributing to. It's geographically different. As you can see, Maharashtra, Karnataka, Andhra Pradesh have very low SC hospitalization as compared to some states like Himachal Pradesh, Haryana, Uttar Pradesh. Similar pattern is seen in ST. Now, it was very difficult for us to get any data on caste. This was legitimately the only data we could get, and that also required going through like multiple data sources, which includes Rajya Sabha, Lok Sabha questions, and every possible data source that would exist. There was no information about other backward classes, general classes, or basic general utilization of SC/ST population. It is very important to look into caste based data in PMJ utilization because caste is one of the most important social determinant of health in India. Having this data will be really important in coming years for PMJ. Our next dimension that we wanted to look into was religion, and we could not find any data on this dimension. Even after going through multiple data sources, there was nothing that was given on religion. For India specifically, religion is a very important determinant whether a person will get service, will access service, where will they go for services. So it's very important to look into data and get access to this data in coming years again. Next dimension we wanted to look into was urban versus rural utilization. There is no systematic data available for urban versus rural utilization of PMJ. So this was our basic look into equity based on utilization and supply of services of PMJ. A small portion of paper was contributed for creating a case for universal population expansion of PMJ. I'll take like few minutes to describe this as well. So basically, government funded health insurance scheme can be implemented in two ways. Either you can give universal population coverage for priority health services, um, like the way Thailand does it, or you can give selective vulnerable population coverage for comprehensive services, the way India does it. So we thought, let's see the impact of out of pocket expenditure between India and Thailand, who are implementing these two different methods of GFHIS. So this red line that indicates India, and the blue one is for Thailand. This the data points that we have plotted is like OOP as percentage of total health expenditure. And what we did was how much was the decline in OOP after 10 years of implementation of a government funded health insurance scheme. So in India, RSBY scheme was launched in 2008. And when we looked in 2018, the average annual decline of OOP was 2%. Then we looked into Thailand. The universal coverage scheme was initiated in 2002 in Thailand. And the annual decline after a decade, that is like in 2012, annual decline in OOP was 6.1%, almost three times that of India. We wanted to create this case for universal population expansion of PMJ because the current model has several drawbacks. The first drawback is of missing middle. So the 75th round of NFSS showed that 50% of the population that is placed between deprived class and affluent section does not has any financial health protection. So this population is basically known as missing middle. So what missing middle means that the lower socioeconomic class is generally covered either by a state health insurance scheme or a central health insurance scheme like PMJ. And the affluent class can go ahead and afford a private health insurance, or sometimes are even covered by social health insurance schemes like ESIS or CGHS. There is this middle population that does not have any coverage from government as well and cannot afford or do not go for private insurance as well. So basically, this population is completely vulnerable to any financial risk um, that any financial health risk that they might face. So this was the first point that we introduced, that we placed why India needs universal population so that we can get rid of the problem of missing middle. Second was that the actual vulnerable population that India has is much higher than the bottom 40%. So as per one of the NHA reports, the difference between monthly mean per capita household consumption between the 40th percentile and 80th percentile of welfare distribution is just 1,000 rupees, which is much less than hospital bill. So which means that person who is on 40th percentile of wealth distribution and a person who is on 80th percentile of wealth distribution, they face similar financial risk or similar risks of going into facing a catastrophic health expenditure if they go into hospitalization. So it doesn't make sense to just cover the 40% population when almost your 80% population is vulnerable. So the second argument was that the vulnerable population in India is much higher than the 40% population that the government is trying to cover. Third was like such a scheme where you are fragmenting the population in terms of who will be covered and who will not be covered is always economically inefficient and expensive because fragmented health systems have higher administration cost. So government spends a lot of money to identify who will be beneficiaries, to enroll them, uh, to spread awareness, and basically on awareness and enrollment, a lot of money is spent. All of that can be saved if we go for universal coverage, and there's a lot of administrative cost associated with the fragmented health system that currently PMJ is following. And the fourth point was inequity. So as I described through the entire presentation, when there is when there's no universal coverage, universal population coverage, there's always risk for inequity. That is, the most poorest person in the bottom 40% will be the person who will not access the care. The most vulnerable population is always going to be left behind, and we will reach a cycle of deprivation where the most vulnerable will become more vulnerable and deprived. So it makes economically and even evidence-wise more sense to go for a universal population coverage rather than a selective vulnerable population coverage. Universal population coverage is also recommended by most of the international bodies, including World Health Organization and United Nations. We hope that the expansion for PMJ will increase and there will be further actions from side of government to work on the equity aspect overall for PMJ. So this was all from my side. I thank you all for being here and attending patiently. I thank our team, Siddesh Thade, Lokesh Krishna, Swasti Deshpande, Jilwasa and Rajit Sikraja for helping in this entire work. I will be very happy to take any questions or take any comments if there are.
Thank you, Sweta. That was a great presentation. You precisely summed up all your findings in a very simple manner. Thank you for that. There are a few questions in the chat box. Arihant is asking, what is the source of your data?
So the source is like different for different figure that we have. If you want to know about a particular plot, I can tell, but overall the data sources have been NHA, that is National Health Account, Rajya Sabha and Lok Sabha questions, and the answers that are given to them by government. Yeah, and then national health accounts and stuff like that. So most of the government databases. We can actually go to the paper, and each of the figure has a detailed description of the data source that has been used.
So I'll be sharing the link to the paper in the video description as well, which I'll be uploading on YouTube, and I'll just share it in the chat box as well. Dr. Vinayak is asking, on what basis is funds to state given for Ayushman Bharat?
So that's a kind of a good question. So that was kind of out of the scope of the study to understand the mechanisms or the framework that exist for allotment of funds. What our paper was trying to look into was more of how much is given than why it is given. So that's a good question, and that's what we are trying to further look into, the frameworks and the criteria that are being used to give this allotment for funds. But as of now, that was like scope of our paper and discussion.
Dr. Sanjeev is asking if you could explain the methodology of your research.
So the methodology was basically this was the policy review. So we used the policy briefs and working papers released by the NHA till July 2021, and we did a scoping review of literature and then snowballing of relevant literature till again July 2021 to get relevant papers and relevant research articles available. Then with respect to policy documents that we used working papers, policy briefs, annual reports given by National Health Accounts, which is the National Health Agency, which is the implementing body for PMJ. So yeah, this was like based on these two sources, broad sources, the policy and then the research literature.
We also have a few questions and comments from Deepak. Deepak, if you can just unmute yourself and ask your questions.
Yeah, sure. Hi, Sweta. Thank you for the very comprehensive presentation. I'm sure to go through all this stuff would have been a very elaborate process, and hats off to you and your team to be able to do that. and this is very valuable information as well. So I just had a few questions to ask. One is that, you said that over 56% of the empaneled hospitals is private. And considering that, majority of our population, like I would say anywhere over 60%, depending on different regions, anywhere over 60% of the people still tap into the private facilities for, accessing healthcare. So isn't it in the right direction? I mean, isn't this a good trend? That, is there real inequity over there? Because where the demand is, that's where the supply is also going. So what are your thoughts about that?
Yeah, that's a good question. Again, like this has been described in very detail in the paper, but I'll still talk about the important points. So before going into whether public versus private hospitals, whether they're equitable or not, we looked into what's the difference in terms of performance or in terms of, so there were various factors that we looked into, which included cost, efficiency, and then services and everything. And we compared the public and private hospitals across PMJ to see basically how that looks. So the services, the cost of services, the efficiency of the services differs a lot between public and private.
Yeah.
So at some places, like for example, in private, there is more tertiary care as compared to public for PMJ.
Yeah.
The hospitals that are impounded for PMJ.
Yeah.
The out-of-pocket expenditure is higher in private as compared to public. The efficiency in claim processing is higher in private as compared to public.
Yeah.
Mortality rate is higher in private again as compared to public. This means
Okay.
that each of the sector has something different to contribute.
Yeah.
So me as a person who is availing services should have the option to access either of them and not be stuck on this is what I have. This
Yeah.
I live in a place which is more empaneled private hospitals, which means I will need to pay more as compared to someone who lives in a place which has more public hospital nearby. So since the things that both the sectors are providing are different, uh, every patient should get a fair choice to where they can go. So that's why
Yeah.
like looking into equity um, is important.
Yeah. So, pardon my ignorance, but I just want to clarify one more thing that is it that all government hospitals automatically get empaneled under the
Yeah.
scheme? Yeah.
Yes.
So,
Also.
probably this percentages may also be varying because, like, is there any statistics which you came across which said that infrastructure wise also the private infrastructure is much larger than the public infrastructure? Is that so, or is it different?
So that's true. Like in terms of services, private hospitals have more infrastructure in terms of ICU, operation theaters, blood supply, blood banks, and stuff like that.
Yeah.
If you're so yeah, that's true. Like private has more infrastructure as compared to public.
All right. All right. And just out of curiosity, like how long had you guys been working on this? Because this seems to be like, this is huge. I mean, this is a lot of data to go through and to collate together.
So we worked on this paper for 2 years before it was published. So yeah, it was huge, and especially the main hindrance in this entire paper was getting data. So someone asked the methodology. So other than just doing reviews of policy literature and research papers, we actually wanted to look into do some analysis on our own. So all the figures that you see have been like made by the authors. So we had to access data for them, and it was like really a task. So it has been a long paper. It has been 2 years. We worked for
But
2 years on
fantastic
this.
job and congratulations to all of you once more.
Thank you so much.
Thank you for answering my questions.
We have a few more questions in the chat box. Dr. Vinayak has asked a few questions. Dr. Vinayak, if I can request you to unmute yourself and ask your questions.
Hello.
Yeah. Hi, Vinayak.
Hello, is it audible? Madam, is Ayushman Bharat available for above 40 people also?
Is Ayushman Bharat available for?
Above poverty level people also. Above
APL.
Above 40?
Above
No,
poverty.
above
above poverty. So yes, so Ayushman Bharat follows like something known as SCCC criteria. So what it has is like occupational and social determinants that they have decided. So in that, what they do is like they surely include all BPL, but then they have some criteria like they include socially backward class like SC and ST, irrespective of their BPL status. So in some of the beneficiaries might not be BPL. So that's an improvement over RSPY. So RSPY only considered the economic disadvantage of population. What PMJ did was it considered economic as well as socially disadvantaged people. So those who are BPL, they will be surely included. But if there are some population who are socially disadvantaged due to their, let's say, caste, they might be included. Then they have also developed some occupational criteria. Let's say if you are, so there are some occupational criteria, especially for urban population. If you are a construction worker, so they have given certain occupations that are also covered. So if you are under that occupation, they do not look into your economic background. You come under their socially disadvantaged criteria.
okay, ma'am.
I hope that
So,
answers your question.
madam, if the person is a middle class person who does not belong to a backward class, so this Ayushman Bharat, they won't get the benefits of this Ayushman Bharat.
No.
Okay. Is all the people covered under Ayushman Bharat, whether they have to go through any enrollment process there?
Yes. So every beneficiary has to go to the nearest hospital that is empaneled under PMJ. They can do that. Then there are some Arogya Doot. So these are people who have been employed by the government or by the whatever the state to help people get a beneficiary card. So every PMJ beneficiary is supposed to have a beneficiary card to avail services. So they have to get enrolled.
Okay, ma'am. Ma'am, one more question. Can they directly go to the private hospital or whether the referral letter is necessary from a government institute?
They can, if they have the Ayushman card, the beneficiary card, they can directly go to private hospital if the hospital is empaneled. So not every private hospital will provide you Ayushman services. They have to be empaneled under PMJ.
Okay, ma'am. Thank you. Thank you very much.
Thank you, Vinay.
We have another question from Tejas. He's asking, despite being one of the major incoming state, why does Maharashtra have low trends in both percentage of eligible population and hospital admission rate? Any thoughts on that?
So let's go to yeah, so that's right. Maharashtra is a major incoming state. So this figure is like percentage of eligible population enrolled, which means that Maharashtra is not doing great in enrollment process. So one thing that needs to be looked into is like Maharashtra has a very high beneficiary population. So enrollment might be difficult to cover such a huge population, or maybe the enrollment machinery is not working very well. So clearly Maharashtra is not doing great in that. They need to look why that is happening, and this needs to improve. Now coming to hospital admission rate per 1 lakh beneficiary. Again, like Maharashtra is not doing great in that. Maybe people do not want to avail services under PMJ, the state people or even the beneficiaries. They want to go for non-PMJ services or something like that. So why this is happening, again, like as I answered for one of the previous questions, why this is happening is really the next step of our work. I can give you hypothesis and what I think. As I mentioned, like maybe the enrollment machinery is not very active, not working very well. Maybe Maharashtra people do not want to use, even the beneficiaries do not want to use PMJ based services. There can be hypotheses, but I cannot give you a very 100% sure answer. Maybe the next talk, when we have finished our work on this topic as well, why we are seeing the trends that we are seeing is really something that intrigues us as well. So we will be looking at in our future work.
If there are any other questions, we can take them now. Otherwise, any personal experience you would like to share, Sweta, while doing the study, sort of the problems you faced?
Yeah, so personal experience was basically it was very revealing for all of us as well, very exciting, and we saw things that we were not expecting to see. Some of the very good unexpected things people have already asked in today's discussion. Those are the things that we also found them to be surprising. As I mentioned, this scheme is huge, and the scheme is directed in a direction which is very important, like covering for like going in direction of universal health coverage. I would like to reiterate to this in this discussion that it's very important to have the right data to go ahead. Like if we are expecting um, to actually make the scheme work, we really need lot of data, a lot of good data, like a lot of granular data and lot of evaluation and changing the scheme based on that. It's the only way this such a huge scheme can be successful. And another comment from my side, which I always say, is like all of this is possible if more money is put into health. What we have currently, we can surely do better than what we are doing. But to actually reach where we want to reach, or what we promise our population or promise beneficiaries, a lot of money needs to come. With the minuscule funding that PMJ is receiving, it's very difficult to provide healthcare to the bottom 40% population as well. So, yeah, and some of the miscellaneous points that were not covered in the discussion were PMJ does not cover outpatient. Outpatient is major source of out-of-pocket expenditure for Indian population. So whenever the scheme is revamped or evaluated, it's very important to include outpatient expenditure. The cap of PMJ is right now static, which means, and this was the same problem with RSBY. So a static cost coverage cap means that RSBY had a cap of 30,000 rupees per family, and through the decade of through the 10 years of its existence, they kept the cap as 30,000 only. So that needs to change. The cost coverage that you're giving to the population needs to change with the changing inflation in healthcare. So I hope that PMJ will go in the direction of not having a static cost coverage, but a dynamic one, like changing the money that they are providing to the households as there is change in the healthcare cost in the country. Yeah.
Yeah, there's one last question that we can take out in the chat box. This is from Ismail. He's asking if data related to religion is increasingly becoming difficult to access in your routine work, or is it only for PMJ?
Religion, caste data are generally difficult only to access in a very good form. So overall, I'll say that it's difficult only, but I was very surprised that there was nothing available at all for religion. Like something should be there. Like for after digging deep for caste, we found something which was like really doesn't show or doesn't tell anything much that is significant, other than saying that there's low utilization in private sectors for SC and ST. But I was very surprised that we were not able to find anything at all for religion, which is like a very important determinants of what kind of healthcare access you will have. So it's low, but it was surprisingly low for PMJ.
I think we have 2 more minutes. One last question. Tanuj, if you would like to unmute yourself and ask your question.
Hi, am I audible? Sorry, there's a lot of
Yeah,
background
yeah,
noise.
yeah, Tanuj.
Yeah, thank you, Sweta, for the presentation. That was really wonderful. I just had a quick question, which I think Siddesh has just answered. Beneficiaries can spend up to 5 lakhs per year. Okay, yeah, that clarifies. Thanks.
Okay, I think Siddesh has already answered that question in the chat box. Thanks, Siddesh. Any comments from you, Siddesh? Siddesh is also a co-author on this paper and also the co-founder of ASAR. Any thoughts you would like to share, Siddesh?
No, I think Shweta kind of covered all of it, and yeah, all of the questions were really interesting. So I don't have anything much to add here.
So thanks a lot, Sweta, for taking out time to do this. I totally understand 2 years was a long period, and I hope the whole team is extremely proud now that this paper is finally out, and I sincerely hope that this reaches the people who are making those decisions, and we have some positive change in the near future. So thanks to you and to ASAR for this immensely important piece of document. And once again, thank you for joining us today to share your work with us. And thank you everybody else. There's a feedback form link in the chat box. If you could please fill that as well and help us improve how we can make this whole forum discussion better for you all next time. If there are any doubts, you can reach out to us. Our email ID is nivarna.for.india@gmail.com. I'm sharing that as well. You can visit our website, nivarna.org. And that's how also you can connect with us. And we'll keep sharing evidence-backed public health information, and we'll keep things updated, and we'll soon share our topic for our next session. 27th May is going to be an awareness session on endometriosis. We'll have an expert, and we'll try to answer all your doubts there as well. So do join us again, and see you all next time. Thank you.